Very warm welcome to all of you. This is our second in series. Once we have started the Renal Info series from Organization of Rare Disease India. I am Dr. Dipanjana Datta. I am a genetic counselor and also state coordinator West Bengal for Organization of Rare Disease India. And it is our effort that we would like to bring forward as a team expertise in different fields for rare diseases so that they can talk and share their experiences. And we promise you that we are trying to get the best in the field. And today we have Professor Dhavendra Kumar sir with us. Welcome, sir. Professor Dhavendra Kumar sir is a recognized leader in genetic and genomic medicine. We all know him, we all look up to him, we all respect him. He holds key clinical and academic roles in UK and India and has pioneered precision medicine initiatives and genomic healthcare projects in low middle income group countries. As a founder of Genomic Medicine Foundation UK and a member of Hugo Faculty of Scholars, his groundbreaking research and influential publication have slightly advanced us in the field of clinical genetics and public health. He is affiliated to the William Harvey Research Institute, Baths, the London School of Medicine and Dentistry, Queen's Mary University of London. Today, we have the privilege of Sir speaking on us on one of his favorite topics, which would be cardiogenetics. And without wasting much time, I welcome Sir, and I'm very grateful to him because the moment I asked him, he agreed. And very grateful to you, Sir, and welcome. And we hope to learn from you today and in future as well.
Thank you, Dipanjana, for a very kind introduction, and welcome to the ORDI series. It's a real privilege to have this opportunity to communicate with all dedicated doctors and healthcare professionals in India who are committed for the management of rare diseases. So as Dipanjana mentioned that cardiac genetics is one of my special interests. So what I thought to really talk about what's actually happening in clinical genomics or clinical genetics, working with cardiologists to manage heart failure. I have to acknowledge my colleagues who have contributed to some of my books, especially on cardiogenetics. The book on the genomic and molecular cardiovascular medicine came out recently, which focuses on all conditions which are of cardiovascular system. So foremost, I think the basic aim of rare diseases management is precision and personalized care. So precision diagnosis is the first point. If you look at all healthcare system have got three areas: diagnosis, treatment, and prevention. And within that, we take into account what is the demography, what is the environment, what is the disease and natural history, what is the epidemiology, and what is available in terms of treatment. And then moving on to much more deeper into the genomics and precision medicine, we continue to make a lot of progress as we are moving. So before we start the treatment, we need to know the diagnosis, and that requires sophisticated technology and the phenotype description and selection of patients in that order. So let me just come back to the topic of the day today. So if you look at the heart as such, so you got to have conceptually two separate areas. One is what is the anatomy of the heart. Okay, we say right ventricle, right atrium, left atrium, right ventricle, and all large arteries and veins attached to that is the anatomy of the heart. And that is the structure. But what drives the heart? What is the electrical system, the cardiac conduction system? And that's just like you just imagine the generator and all the grid system. So starting from the SC node, then coming to the AV node, and then left and right side of branches, and also the branch going to the left atrium. So all these things are very tightly controlled and managed right from the beginning of the fetal heart, as early as 10 weeks, 11 weeks, the heart starts beating. And that continues throughout the life, right to the point when person is declared dead. And even after death, there is evidence that electrical stimulation might still persist in some form. The electrical system requires very sophisticated uh, ion transport through the ion channel proteins, which is a separate area within the cardiovascular system. So if you look at the cardiovascular medicine as we understand, so you have to separate the blood vessels, vascular, the structural part which I mentioned, and the functional part, which is the electrical part. That's where the arrhythmias and abnormal conduction abnormalities come along. Then the many systemic diseases, mostly like infection or metabolic conditions, connective tissue diseases, immunology, and the drug side effects of drug, they also involve heart. And in fact, these are the most troublesome, the whole lot. Now, just to coming on to narrow down the inherited cardiovascular diseases. So broadly, we have three categories. One is the heart muscle disease, cardiomyopathy. Second is the blood vessels, mainly aorta or small or medium-sized arteries called aortopathies. Marfan syndrome is the hallmark in this group. And the channelopathy is essentially what happens when sodium, potassium, calcium ions are coming out of the cardiac cell and generating the cardiac rhythm. Disorders like long QT syndrome, Brugada syndrome feature. So today I'm only going to focus on the cardiomyopathy side, because as you can imagine, the field is very broad. And the reason I've chosen cardiomyopathies today, because this is the main bulk of conditions, they all manifest as heart failure. So what is heart failure? This is a model described by Dr. Lewis, a British cardiologist, a condition in which the heart fails to discharge its contents. And there are many causes for that. Left ventricular systolic dysfunction and going, and then eventually syndrome of the heart failure. And it could be managed, compensated, could be totally failed when there's nothing could be done. And then syndrome of the heart failure may manifest straightforward as a certain cardiac death or in the form of progressive pump failure. And so when it is totally decompensated, then really the cardiac transplantation might be the only solution. So the clinical presentation of heart failure, as cardiologists know, and they have taught me, in many cases it remains asymptomatic, very non-specific symptoms, little bit tiredness, aches and pain, or not feeling that well, sleepy while working, going to sleep, all those things, mild chest pain, but most of these symptoms are not shared by the patient, by the person, to friends or family. They don't go to doctor, and there may be family history, there may be history of certain cardiac death in the family. So if you look at heart failure, so naturally, if somebody got a high blood pressure, that will contribute. If there's a volume abnormality, for example, a person who is very obese, weighs 100 kilogram or 85 kilogram, so on a simple way, the volume in the blood circulating would be too much. And of course, the structure of the heart, whether it is a primary disease like cardiomyopathy or abnormality in the rhythm, all contribute to heart failure. And interestingly, all these sectors have got genetic diseases. Some are common, some are rare. So there are, broadly speaking, there are two patterns of heart failure. One is called diastolic heart failure, when the heart is so rigid, so thick, it's just not relaxing. So diastole means relaxation of the heart. And then the contraction of the heart is called systole, when the blood is pumped out. When the heart is already dilated, then there is no systolic systolic function, and as a result, patient has got systolic heart failure. This is a broad definition which cardiologists use every day. Now, if you look at variation of causes or the natural history or background history of the chronic heart failure, so you see, I mentioned already this thing. So genetic factors which I'll talk about, the toxic alcohol, ischemic heart disease, hypertension, metabolic, especially in obesity and type 2 diabetes mellitus, and congenital heart disease in children. And post-myocarditis, post-rheumatic is common in India. In fact, post-myocarditis became a problem. Those who succumbed to COVID, and then I think remains a problem. And chemotherapy is well known to oncologists. In fact, the cardio-oncology is a distinct field now. Now, if you look at the pie chart of this, say, ischemic heart disease, or what you call the coronary artery disease, associated with hypercholesterolemia, remains a very high bulk of the heart failure. And as we know, there are some genetic conditions in ischemic heart disease as well. Hypertension, we know there are some primary conditions which lead to hypertension, mainly kidney and endocrine conditions, and congenital valve disease, and of course, cardiomyopathy is 15% or 20%. I think it depends where the data was collected. If you look at the spectrum of genetic factors, so starting from a very purely environment like rheumatic heart disease, autoimmune, viral, alcohol, toxins. So these are one end of the chart. And do we have genetic factors in the background? Yes, that's where we come to polygenic multifactorial. So environment plus pre-existing genetic or genomic factors combined, that's called the complex heart disease. But moving on to inherited cardiomyopathy, so that is a good area I'll leave it now in this presentation. So let's just complete the complex heart disease I mentioned just now. This is a model which everybody has to understand. So there is an environment where we are living, pollution, toxins, all those things. And we have within the genome, there is epigenome, which actually analyzes or selects the environment what's relevant to the main genome function, the risk factors, subclinical disease, and eventually cardiovascular disease. So this model applies to cardiology, applies to maybe other systemic disease as well. So before I move to cardiomyopathy, I thought I'll mention about the congenital heart disease. And children are born every day with the congenital heart disease. 1% or 2%, some of these are syndromal, mostly they are non-syndromal. Interestingly, there are genetic conditions, about 8%, which are very rare conditions, and follow the Mendelian inheritance, where one of the manifestations could be congenital heart disease. And it is a very important factor for childhood heart failure. Now, just moving on to inherited cardiomyopathy, I mentioned dyspnea, sudden death, syncope, angina, no symptoms. All these are part of the clinical presentation. Now, one of the important classification, we have many classification systems for cardiomyopathy, European, British, American, you name it. But one of the very important classification system by Liz Arbustini in Italy is very practical classification called MOGS classification. M stands for morphofunctional phenotype, O for organ system involvement, G for genetic, E for etiological annotation, and S for stage of the disease. That's where the New York Heart Association classification is used, which is, I mean, it is a bit complicated, to be honest. Not many cardiologists, they prefer to use MOGS classification. But when you are documenting a cardiomyopathy for, say, research purposes or for collection of patients for certain clinical trial, then MOGS approach is very good. So in a nutshell, we have got 5 different types of cardiomyopathies. Hypertrophic cardiomyopathy, dilated cardiomyopathy, as you can see, and then restrictive cardiomyopathy, and in left ventricular non-compaction and arrhythmogenic right ventricular cardiomyopathy. So I will discuss these in some detail. Now let me just introduce you this very complex family. So this young chap at the age of 32 years dropped dead. He was a bank manager. It's a sudden death. There was no previous warning at all. His bereaved wife approached because she was concerned about the risk to her 11-year-old surviving son. And then the background that this chap had some mild symptoms, some red flags, but no action was taken. And although he had some investigation carried out, and there was some degree of asymmetric septal hypertrophy, but not much evidence of heart involvement. And so we managed to do the autopsy, was done, and we managed to get a cardiac tissue sent to a special lab. And there was some degree of myocyte disarray. They raised a question of hypertrophic cardiomyopathy. There was also secondary abnormal thickening of the blood vessels, which was actually the phenomenon well known in hypertrophic cardiomyopathy as a compensatory. The famous cardiopathologist in London, Professor Mary Shepherd, wrote in her report, lack of sufficient myocyte disarray enough to make a diagnosis of hypertrophic cardiomyopathy. So the diagnosis remains doubtful. And that is a picture, as you can see. Now this is a picture which everybody would agree is very typical of hypertrophic cardiomyopathy. As you can see, thickening blood vessel, a lot of disarray around here. And so that's what the picture was. So we were satisfied with the clinical and the pathological diagnosis of hypertrophic cardiomyopathy. But when we tested to carry out the limited gene panel testing, we found a pathogenic variant in exon 16 of the MYBPC3 gene, myosin binding protein C. And this is the cardiac sarcomere family completely shown, and this is that's where the mutation or the variant was found. It was agreed to be pathogenic, and we confirmed the diagnosis. So eventually, what we found that his father there was no connection for some time, but his father was treated in London for chronic heart failure, and the cardiologist arranged the same investigation, and he was found to have the same variant as his son. He was at that time 72 years of age. And then we also found that his surviving brother who came forward and also had another condition, other clinical signs of type 1 neurofibromatosis that confused us because NF1 can also be associated with hypertrophic cardiomyopathy. But he had the MYBPC3 variant, but not cardiomyopathy and not symptomatic in terms of heart failure. But he had a 9-year-old son who was not tested at that time because of age, but he was given the risk. So eventually, we also found that one of his uncles also had, who came forward pure by chance, and he was found to have the MYBPC3 variant. So eventually, from one sudden death, we managed to go to the family in an extended manner and establish not only the diagnosis of hypertrophic cardiomyopathy, but managed to counsel, arrange targeted, personalized surveillance to other surviving members, mainly younger members of the family. So the genetic basis of cardiomyopathy has been a research topic for a long time. So what we knew that sarcomere being the bulk of the proteins, then cytoskeletal proteins and the nuclear alveolar proteins and cell adhesion proteins were all associated eventually leading to the picture of cardiomyopathies. So all proteins in the heart muscle myocardium are very complexly or tightly packed, and they have the capacity for remodeling. That's why any ischemic damage, any toxic damage, heart takes its care, and new protein molecules, they come up and they heart is adjusted and to minimal heart failure. But when there is a primary involvement or because of mutation in certain proteins, then the capacity for remodeling is limited. And that's where the, the progression to heart failure in inherited cardiomyopathy is much quicker compared to the acquired type of heart muscle involvement. So if you look at the heart hypertrophic cardiomyopathy, different proteins, bulk of these are sarcomere group of proteins. And if you use a prismatic kind of model, you find that there's one single phenotype of hypertrophic cardiomyopathy, but from genetic point of view, from the molecular point of view, you can dissect that into many different types. And the cardiac sarcomere, this is very famous model proposed many years ago by the Seidman lab in Harvard. And that remains a very good model of the heavy chain, the medium chain, and the thin chain, all thin molecules. They put together and they coordinate and they make the heart muscle fiber. And then that's how they respond to that electrical stimulation in a very coordinated manner. And then heart pumping action is maintained. So the hypertrophic cardiomyopathy is common, 1 in 500, and very difficult to make a prognosis. A lot of heterogeneity. I showed the clinical picture, the ultrasound picture, and the cardiac MRI picture are very typical, and it remains a mainstay of cardiac genetics. As you can see, the hugely thickened heart, there's hardly any space left in the left ventricle cavity, including the right ventricle cavity as well. So sometimes what happens, you have not only one sarcomere protein, but also the other protein also involved. Like in this family, the combination of MYBPC3 plus myosin heavy chain 7 molecule were involved because inherited from different directions. So as a result, those who had both molecules involvement, the onset was much more vigorous and earlier. For example, this boy died at 17 years and then had both molecular involvement. And this one also had very early onset of involvement. So that's why the gene panel testing or gene sequencing, what we have today, is extremely important because it's not by definition it is not monogenic. By definition, it is oligogenic. I mean, there are two different genes within the same family involved are involved, and we are now increasingly getting into much more into deeper. For example, there are other conditions which are also involved. The PRKG, which is a gene for Wolff-Parkinson-White syndrome, and that also leads to the hypertrophic cardiomyopathy. And the pseudo-glycogen disease called Danon disease, which is because the LAMP2 has the same picture like hypertrophic cardiomyopathy. So just imagine these variants or these genes were involved with the sarcomere gene as well. The clinical picture would be much more complex, much more vigorous, and with the earlier onset of the disease. Now, in this picture, which is given to me by Liz Arbestini from Italy, and the child had a myosin heavy chain gene, and also as well as mitochondrial DNA involvement. And the picture was much more vigorous as a child. And eventually, I think I remember the child was managed with a heart transplantation. And so the point I'm trying to make that in hypertrophic cardiomyopathy, we think about a single gene, but actually the different combination of various genes are also well known. Now, in the same context, there are some other groups of proteins, especially the Ras-MAPK syndrome, Rasopathies. This boy got a neuron syndrome, very classic picture. I've got permission to show, and he was found to have the PTPN11 mutation. And actually, he presented with with a heart failure cardiomyopathy, but because of his face appearance, the pediatrician thought about neuron syndrome. And we also know type 1 neurofibromatosis. The many syndromes are now in rasopathies, and they have a very classic association of hypertrophic cardiomyopathy, and they do present with heart failure. So the management of hypertrophic cardiomyopathy, we are getting much better now. The genetic testing is a key if you're going to advise for accurate genetic counseling, or selecting family members who would be put for targeted close surveillance. And of course, the bulk of the management of the patient who has got a condition plus heart failure remains within the domain of cardiologist. And so clinical geneticists like myself and genetic counselors, we work together. So we have got, in the UK, every large teaching hospital has a heart failure team, multidisciplinary team, in which there is a significant role of molecular genetic lab person, clinical geneticist, genetic counselor, and, and, and other people, and of course the cardiac radiologists as well. So we work together to manage these patients. Now, one condition which is very intriguing, in fact, I'm supposed to be, there are many families in India, I'm told by Professor Ajay Bal from PGI Chandigarh, and this is called restrictive cardiomyopathy. It is really a misnomer, or we don't know whether it is an entity or just a spectrum within the hypertrophic cardiomyopathy. As the name indicates, the heart muscle is restricted, like in hypertrophic cardiomyopathy, it's not relaxing. And some of the metabolic conditions, they have a constrictive cardiomyopathy. For example, in Fabry's disease, which is the lysosomal disease, there is a restrictive pattern. However, one of the important molecule in the sarcomere family, troponin I3, is mutations in or variants in this molecule or in this gene are associated with restrictive cardiomyopathy. It remains a problem. It is very difficult to treat the heart failure in this condition, and these patients, they are good candidates for cardiac transplantation. Now, there is some success now in treating the hypertrophic cardiomyopathy, mainly the obstructive type. This new drug called mavacamten, some of you might be aware, it is also, I think, available now in India, a very expensive drug. So essentially, you can see that there is a normal sarcomere, the sarcomere in the hypertrophic cardiomyopathy. Then after the mavacamten treatment, it is restored as a normal sarcomere. And it is basically, it is a targeted inhibitor of cardiac myosin. So so it is coming along. There are some side effects which I don't have time, but I think those who are interested to know a bit more about that. So it is really the outcome of genetic understanding, genetic genotype versus phenotype correlation, and then finding the the, the role of cardiac myosin inhibitor, and then to manage hypertrophic cardiomyopathy. We need large trials, and people are jumping, prescribing it without much. In fact, I was very unhappy to find that some in India, they did not do the proper genotyping, but they prescribed mavacamten based on the clinical picture of hypertrophic cardiomyopathy. This is a serious mistake. One should never, ever prescribe mavacamten without the proper genotyping of hypertrophic cardiomyopathy. That is a take-home message. Now, moving on to dilated cardiomyopathy, it is really an enigma. It's a rag bag of condition. It is hugely heterogeneous, and it can be very rare, up to 1 in 10,000. One third are genetic, one third combination of genetic and environmental factors, and one third are pure toxic, pure environmental. Within that, we have different varieties of genes involved, including the mitochondrial, and many recessive metabolic conditions in children also manifest with dilated cardiomyopathy. As you can see, the heart progressively becomes dilated, fragmented. It is the ultimate picture from a patient in Oxford who died, and actually he was given the heart transplantation. He survived. This is the heart which was removed from him, and I don't know about the genotype of this patient, but that remains a textbook picture which I always use in as I mentioned, the mitochondrial DNA involvement is extremely important to investigate dilated cardiomyopathy. So the natural history of dilated cardiomyopathy could also be very variable. Again, using the prismatic approach to understand this condition, so there are a huge number of different type of molecule systems like dystrophin, laminopathies, desminopathies, mitochondriopathies, and apart from the sarcomere involvement, there are a huge number of other molecule systems involved, and which may be recessive, maybe also dominant, could be even X-linked recessive, like in dystrophin type. And it is a real challenge to manage. And the symptomatic treatment is applicable, but eventually it is really the cardiac transplantations. So some of the examples of common proteins, molecule, lamin AC is very important. They usually start with the conduction abnormalities. And sometimes dilated cardiomyopathy may also have the skeletal myopathy. So full neurological workup is also important in a patient with dilated cardiomyopathy. One should never hesitate to ask a neurologist colleague, or could you please examine this patient, whether the patient has got any degree of muscle weakness or motor signs. So that will help us to have a very good phenotype and as well as to focus on molecular testing. Now, the other type of rare cardiomyopathy is called left ventricle non-compaction. So just imagine the brain, I always give example, brain develops in layers. So the earliest layer and then the youngest layer, they are packed. And when there are conditions, these brain layers are not properly compacted and there are different brain malformations. Similarly, in the heart development, there are layers of the myocardium. They are packed. And if they are not packed together, that's called non-compaction. It is developmental, hugely heterogeneous, may present as a congenital heart disease, could be associated with chromosomal abnormalities, may look like DCM, and quite difficult to manage. Now, the top picture is from a 16-year-old girl, one of my patients, who was admitted in a massive heart failure. In fact, she had no hope to survive. Immediately, the cardiologist picked up the phone and registered her for transplantation. Fortunately, in the morning, within 8 hours, sadly, a young boy died in a motorcycle accident. And his heart was given what his family agreed, and the heart was put in this patient. And this is the explanted heart. And this woman has survived. Now she's got 3 children. So that's a success story. But if you look at the sieve-like appearance, the pure in Hindi we call chalni type. I think that's right, what the sieve appearance of the myocardium, both right and left ventricle. I put these slides also together to in comparison with the hypertrophic cardiomyopathy and the dilated cardiomyopathy. We don't know much about the genetics of non-compaction, but 1/3 is supposed to be sarcomere related, but it is a rare condition. But one has to think very carefully. The MRI picture is very typical, and the pathology, as you can see, the gross heart, and again, no treatment at all, no pharmacological treatment. It has to go straight on the cardiac transplantation register, as it happened in this case. Now, other cardiomyopathies, which is a real challenge, because it starts as arrhythmia. It does not start as a cardiomyopathy. That's why it's called arrhythmogenic right ventricular cardiomyopathy. It's a long name because predominantly there's a right ventricle involvement. But now we know it is not limited to right ventricle. Can also involve left ventricle. So the latest terminology is called arrhythmogenic cardiomyopathy. That's what we have agreed now. But historically, it's called ARVC. As you can see, there are muscle, there are damages. There is a fibrofatty tissue. So what happens is the damaged myocardium is replaced by the fibrofatty tissue. And that results in the conduction abnormalities, arrhythmias, and as well as the poor heart muscle function, which is cardiomyopathy. So a combination of arrhythmic element plus heart failure in this condition. Quite serious because it's very important cause for sudden death, is sudden cardiac death. Parts of Italy, mainly in the South Italy, there are many pockets of families with a highly prevalent ARVC. So if you look at the fatty infiltration and then all adipose tissue, this is a normal appearance of the right ventricle. A huge difference, you can see that. And that's what actually the pathology of in this condition. So what actually happens, it's not a heart muscle disease. It's a disease of the cardiac muscle junction, so junctional proteins. So as you can see, if you've got two bolts put together and there is a joint in between, if the joint becomes weak, the adjoining bolt put under a lot of pressure. So as a result, that bolt can also get damaged. So precisely that's what happens in this condition. So it's not a primary heart muscle disease, but secondary because of the junctional proteins. So these are the junctional proteins, as you can see, very complicated, and they are actually putting them together to myofibrils, fibrils, or myocytes. And there are, of course, in the whole heart, there are trillions and trillions of these molecules. And this could be a serious condition. It can present as early as 6 months of age and as late as 40 years of age. This is, of course, I mean, they have a typical ECG appearance, epsilon waves, and then, of course, the management protocols are there. This is based on the protocol published by the Sydney team, Dr. Samsarian team. So these are also called, these junctional proteins are called desmosomal proteins, and the plakophilin, desmoplakin, and there is a recessive, most are the autosomal dominant, but there is a recessive type in the Greek island called Naxos, and they have a very curly, funny hairs, thick palmar and plantar skin, and in fact dry skin, and cardiac phenotype of ARVC. So there is a treatment now on the horizon called glycogen synthase kinase 3 inhibition for ARVC. So the trial was named Target, uh, and that has produced some results. This drug is not yet available. I think FDA has just licensed this, but I'm not very sure about the status of its availability. But what the point I'm trying to make that the clinical and genetic knowledge has led to the development of new drugs. Now, cardiac amyloidosis, as we understand as a medical person, is a secondary to chronic infection. So amyloid, like we know, the kidney got this cheesy protein-like substance deposited in liver, kidneys, and some glands, and gradually these organs become functionless. That is the end point of chronic infection, whether infection be tuberculosis or could be something else. That's what, as a medical student, I understood. But they are proteins, amyloid proteins, mainly the transthyretin. And there are some primary amyloidosis conditions. Some are recessive, but mostly they are autosomal dominant. They predominantly involve the neurological system as a peripheral neuropathy. But in some cases, there may be cardiac involvement. The cardiac amyloidosis is a nightmare. And it's a rare condition, and there is a special clinic in London at the Royal Free Hospital, and that's where we send our patients. And so it can be, we look at this is a normal myocardium that is after the amyloid deposition, and then the myocardium becomes quite a rigid, thick, as if somebody has really put a lot of cheesy material in the myocardium. And then very complex molecular pathology. And the main gene is called TTR, transthyretin gene, but there are some other genes also involved. So mutations transthyretin are basically for cardiac amyloidosis. And the presentation is, of course, heart failure. And again, treatment is transplantation. But now there are some treatment on the horizon, As you can see from this slide, this is a recent paper. Those who are interested can read that. And similarly, a new paper arrived, I think, only a few weeks ago, which is highlighting the current status of the transthyretin cardiac amyloidosis. This is extremely rare condition. I don't know how many patients in India. I've spoken to my colleagues in cardiology. They don't know that. So they are there, but they are hidden under the big, infection workload. So just to complete the story of heart failure, we need to remind ourselves that bulk of the heart failure results from the ischemic heart disease or the coronary artery disease. So if you look at historically, when we had the Human Genome Project completed, we had a lot of information about the single nucleotide polymorphisms. So this technology of genome-wide association studies was applied, and everybody was excited. We find to get a peak at chromosome 9, and that's called the Manhattan Project, Manhattan chart, like the New York Manhattan, scenario, a lot of tall buildings. And so initially we thought, oh, we got answer of the strong genetic susceptibility for coronary artery disease. But later on, we found out that it was not specific, and it was just a biomarker or genetic marker for CAD. So, but now the same, we collected a lot of information of the single nucleotide polymorphisms in relation to CAD, hypertension, you name it, many other conditions. They satisfy the concept of multifactorial polygenic inheritance, as you can see from here, and there's a threshold and all those condition involved. As a result, some scientists developed in Harvard what you call the polygenic risk scores. Used to be heritability estimate based on monozygotic and the dizygotic twins. So the polygenic risk score is a statistical expression of all findings, the clinical picture, the background, the age, the lifestyle, and the pattern or SNPs in the person. It is not diagnostic. It has got very limited predictive power, very limited. Unfortunately, some of the private labs in India are offering polygenic risk score as a mean for making a diagnosis for coronary artery disease, which is unfortunate, wrong, totally wrong, and as well as advising the prediction, advising the prediction for this condition, which is again not correct. So I mean, you can make some categories based on the family history: high risk, medium risk, average risk. It can be used for guiding the surveillance, but not for diagnosis. Again, it has got very limited predictive power because CAD is a very important risk factor for heart failure. That's why it is extremely important to have a good grasp of polygenic risk score in this condition. And there are many studies have come up now because this risk scoring can also be useful for other disorders like stroke, atrial fibrillation, hypertension, type 2 diabetes. So the concept, the proof of concept is there. That we have got a very good statistical tool which we can apply, but not for not for diagnosis, not for guiding the treatment. You can select out patients within a family, within a community where there is a high risk of coronary artery disease or type 2 diabetes or stroke and all those things. Otherwise, it is very limited. And I would strongly encourage that those labs which are offering, we should not really support them, but advise our patients accurately. Now, coming to diagnostic genome diagnosis, so coming back to the diagnosis of genome diagnosis, we got whole loads of multi-gene panel for cardiomyopathies. Some of these panels are they are available commercially. They can have 200 genes to 300 genes, but it's not complete. Therefore, the next generation genome sequencing is the best way to take forward. Targeted clinical exome sequencing is very good, and the whole exome sequencing is available, getting much cheaper. Whole genome sequencing has a limited role unless they are multi-system presentations. RNA sequencing is important to clarify the various unknown significance. And of course, if you have a complex picture where there is an involvement of brain, eyes, hearing, and whatever, and you suspect mitochondrial disease, then go for mitochondrial genome analysis. So that is the present genome diagnostic picture. And, and in most cases, we go back to single genome testing to validate our finding, because single testing takes time and so it's not commonly used. But combined with the NGS, it is very useful. And we have to understand the importance of variants which have no significance. So database searches, proper cardiac database searches, and the population database search is very important. The difficulty is that most of the data is derived from the European origin, Caucasian population, with very limited Spanish or South American called Hispanic people, and extremely limited or negligible from South Asian or even African. So when you are looking for a variant of unknown significance found by a lab in India, in Mumbai or Bangalore, whatever, then you have to be mindful that the data you are going to search may not be typical of the Karnataka or West Bengal or Tamil or tribal Assam. You'll be very surprised. We don't know that variant has got any clinical importance, or is just there because of what we call the foundation, the founder effect. It's been there for generations. So why, if it has been there for generations, how could that be significant? No, it's not significant. For generations survive with that mutation, that variant, so how could that be pathogenic? So all this question, so we have to go back to the family history, go back to the clinical picture, and analyze it very carefully. And then that's where I think you have to come to a decision, because if you decide a variant of clinical importance, it will have a serious implications, because you might end up advising the family member who's otherwise healthy to undergo all kinds of surveillance, will go for preventive medication, and even go for preventive heart devices implantation. So that could be quite a you'll make a patient, healthy person of the family, unhealthy. So the application of loose talk about the VUS, which is actually happening, some of the reports I have seen in India are so badly written. So I think the cardiologists and all of us, we have a duty to make sure that we are not, we have to take VUS very seriously. So because patient has put out 20,000 rupees, so we have to be very careful what actually is there, okay? Now, the other ways of looking at, this is a consortium developed to how to sort out variants, and this is the research one, it's called Hermes Consortium. I don't think it has got much clinical application, but as a concept, you can see that you can have the baseline allele frequency, then you can decide whether it is going to be heart failure onset or progression, whether it's going to follow the low, modest, or serious high risk. So you can have all these indicators based on using that data. So just to finish up, the precision genomic management of heart failure, more than a heart disease, is a mutation known, unknown, genetic counseling, clinical exome sequencing, and all those elements here. Then, so you can have a good landscape of the family and what's actually happening. Then you tailor your genetic advice or genetic counseling and the cardiology targeted surveillance in a very carefully coordinated manner. So in conclusions, The chronic heart failure has got a lot of clinical inherited factors in the background, vastly heterogeneous, major group inherited cardiomyopathies, and a Mendelian mitochondrial complex genotypes, very poor correlation with the genotype and phenotype, very poor. And the diagnosis is essential genotyping. Then, of course, it is the multidisciplinary chronic heart failure management in all cases. So genetics or genomics plays a major part in the MDT of chronic heart failure. Thank you very much. Thank you.
Thank you. Insight into it. And I'm really glad that you touched upon the polygenic risk score, because I was intending to ask you about it. We have few questions from the viewers, but before we go there, I just have one question to ask. So, when we are looking at all these cardiogenetic genes, one of the trouble that we face are mostly these genes are both autosomal dominant and autosomal recessive. And it seems that they do have a dosage effect, and in some cases, they are also digenic. So, how complicated do you feel, interpreting the genetic reports goes, and how important is it to do these family studies to actually understand the effect of these genes?
Sure. Yes, it's a very good question. I think, as I mentioned, I think the digenic or oligogenic etiology is there. So that's why whether you define a single gene disease or monogenic, I think that may not be correct in that respect. I think you have to look at, one thing is very important from clinical point of view, it is the age of onset and the progression of the cardiac functional compromise, and then eventually heart failure. Heart failure is when you say heart failure, that is really the ultimate point. Other we have missed the earlier stage of the condition of the patient. So if you have done the genotyping, and there's, as I mentioned, mitochondrial plus the myosin heavy chain, or beta heavy chain, so you will know from the start the clinical course is going to be very different in this patient or in this family. I'm not. It's quite likely there could be some mitochondrial mutation came from one side and one direction, and then the pre-existing autosomal dominant variant of a mutation from other side, and then the child got, as I mentioned, the child was only 3-year-old little girl presented with the left ventral hypertrophy, and then there was a other boy who would drop dead. The large family of from Italy. So there are many examples like we have. So I think the clinical relevance of genotyping is great. Okay, you know that you're talking about monogenic or digenic or oligogenic. There may be some copy number changes as well. So now present day, you know that when you go for whole exome sequencing, you have the option also to include the copy number changes. In fact, the one I use regularly in my practice, it has got inbuilt copy number variants as well. So you also got the genomic loss or gain alongside the selected genes. So we have to, eventually it is the clinical course and the outcome, the best guided by this finding. I don't know whether it will make any difference to drug treatment, because again, if the patient has got digenic or oligogenic, say for example, mavacamten, cardiac myosin inhibitor, may not be that effective. Okay, the selection of drug, we're prescribing very expensive drug. As I mentioned, there are some patients we prescribe mavacamten without genotyping. So drug is very expensive compared to the initial cost of sequencing. Think if you had done earlier, so you would know, okay, whether mavacamten is going to work or not, And of course, as a genetic counselor, you will also explain to them. Thank you.
Yes, sir. So we have a question which asks, actually, which is something on this line about, but on the side of variant of uncertain significance, and he's asking your experience on this. And before you answer this, I would like to ask you something about, sir, we know that there are certain cardiac genes which have different allele frequency in different population. So even these variants, which are sort of very important in one population, might not be important in the other population. And sometimes these variants association, like what we look at the ClinGen for, that it can change the interpretation. So in perspective of cardiogenetics, like variant of uncertain significance becomes very difficult to interpret. So what are your experiences on that?
Well, yeah, which is a good question. I think we don't have much data, different populations, and that's the real challenge. I think we have to be pragmatic. Rather than worrying about the population reference data, we have to go back to basic clinical parameters. So we have to go back to re-examine the patient, look at the cardiac MRI picture or carefully, look at the family history, then decide and what is segregation, as the question asked about segregation. If there's somebody else affected and you also investigate that person and see how many are there who are clinically normal, but with the same variant. So if there are more people who are clinically normal, um, and then they have the variant, so the probability of variant being significant would be a lot less. So if you go, many people just straight jump on the RNA and the functional study, which are very difficult, as you know, not many labs are doing it, and becomes a good research, a PhD topic, but not clinical relevance, because you've got to advise the family. And my practice to go
That
back.
actually would have been my next question. That's are you using, because when I went for this last conference, I saw everyone using RNA-seq to actually, interpret these VOUSs. But are they really useful?
No, I'm not. I think, as I say, it's a good research question. I mean, I have done in few cases, but I mean, the probability of success is very small, very small. You've got to be lucky to find that evidence. But I mean, take for example the family I presented. We had no. It was a single gene. It was a 5 gene panel at that time historically. So what we did in that person who died, I kept on pushing the cardiac pathologist to look at the slides, and the slides were lying somewhere in a different lab. And then the Professor Mary Shepard said, "Oh, there is a microarray, a disarray, myocyte disarray. So this would be MYBPC3 variant would be significant." Initially, the question was, could that be significant? Answer was uncertain. But eventually, we established that variant was MYBPC3, I mentioned the family, based on the cardiac pathology phenotype. So I think that's the way to go in clinical practice. And that is doable. RNA sequencing is expensive, and who is doing it? What methods are they applying? Because it keeps on changing. And then what's the validity of RNA sequencing? Again, the RNA sequencing data, how was it compared with the existing data? Well, there are many questions. It is very tempting, but I think, very limited scope, very limited scope. I will
Yes.
not bother.
Sure. And I think the tissue in which we would work about the RNA is also very questionable. Like, what tissue exactly should we use for the RNA-seq? Because blood might not give us the answer. Like, we might need some other
Then
tissue.
again, then the question will come up, what is the basis of doing the cardiac
Exactly.
biopsy?
Exactly.
I mean, the cardiac biopsy, okay, you can go to this area, but may not have the pickup. We can't do the multiple biopsy. Unethical, dangerous,
Yes.
legally challenging. You could be in risk.
Legally, it's ethically wrong. Exactly.
Both,
So
both legally risky, also legally. You could be liable for serious damages.
correct. Sir, we have one question from Shushma Verma. She asks that which gene is most important for cardio disease? So I and your Indian experience, yes,
Oh,
difficult to answer.
I think that's a difficult question. I mean, as I mentioned in my presentation, and also in the concluding slide, so far the genotype phenotype correlation is not strong. I think because when you say there, when we know about within the sarcomere family, there are 15 different molecules. I mean, you saw the big chart, and so MYBPC3 is supposed to be very critical. I mean, there's some study was
Hello.
in Oxford. They found MYBPC3 was a good indicator for sudden cardiac death in a young person. But I think that data is.
Hello.
Hello, yes. So I'm not going to point out to a single gene for that purpose. I think,
Yes, sir.
yeah.
Yes, I believe it will also be different in different parts of India. That's my opinion. I would say, like
Take,
what.
take for example, which Dr. Sangraj or CCMB finding of 25 base pair MYBPC3 deletion, which is very, which
Yes, sir.
is which is very popular in India because there are certain populations they have got that. And initially, it was thought to be very important diagnostic, and but I think now it's cooled down. It's okay.
Yes, sir. So one last question and we end the session. There's a lot going on with the RNA-based gene therapies. Like we have one ASOs which are developed from titinin and laminin and certain siRNA-based therapies which are based for the MYC-BCP3 gene. So what are your insights into these therapies? And I don't know, are UK or have you seen like these trials working or any progression on these trials?
Not to my knowledge, there are many trials undergoing, and but I think antisense oligonucleotide therapy, so even the primary muscle disease has not been that helpful. I think the main focus nowadays is if you can uh, uh, focus on certain molecules, and then whether they are protein kinase inhibitors or the cardiac myosin inhibitors, I think those are more important than RNA interference. I mean, of course, it's a good research area, but I'm not aware of any new drug coming along which is useful for.
Yes,
I
sir.
mean,
So,
give a
oh,
couple of examples of ARVC and also,
yes.
but it is mostly supportive treatment using electrical devices. For example, biventricular pacing is very important for heart failure, which is done in most cases to support the coordinating function, the pumping action of both the right and left ventricle by putting devices,
Yes, sir. So, before we end, we have just one last question that has come in from Dr. Aparna Bahushali. She asked, where in the algorithm would you advocate genetic testing? I think you have answered this, but then again, the question is there.
Well, I would say as early as possible. I think, as I mentioned, I think because you'll be spending far too much money and doing the cardiac investigations and everything you would like to do. If you knew what you were dealing with by doing genotyping, it will, I think, make much more um, helpful not only to the cardiologist but also to the family. I mean, you as a genetic counselor would rather know that, and so you can sit down with parents or the person and his or his wife or husband, what exactly happening. I mean, because that's your job. You need to have that information. So I would say, I think the threshold for genotyping, in fact, I mean, as we now say in many conditions, genotyping first. Then according to that, you decide whether how much is the radiology done, how much is the biochemistry done, how much is the protein profiling done, and that's where I think the multiomics is coming along, which is, of course, another area of my interest, multiomics. So genomics and then multiomics like proteomics, metabolomics. using the epigenome studies, then working out the whole picture. Right now, what happens, patient goes right from A to Z, all investigations carried out without any purpose. All radiology is done without any purpose. Electrophysiology is done without any purpose. So by the time you have done genotyping, you've got bulk of information. And cardiologist has no idea how to make of it. And you can go to hospital, big bundle. But if you've done the genotyping, you become very straight direction. Well, this is going to be the case. We have to follow, investigate now from clinical relevant investigations.
Yes, thank you so much, sir, for the very insightful talk and a wonderful discussion. And we are at the end of our second talk at Rare Info series. We thank the ORDI team, this platform, for helping us, organize this. And our very next talk would be something again back to the kidneys. And we have our expert, Dr. Ashita Gupta, who actually, let me tell you, has is one of those who have actually written down the guidelines for Alport syndrome transplant. She is one of those experts in that team. And we will be talking on echoes from basement membrane, diagnosing, treating, and managing Alport syndrome. I had this opportunity to work very closely with her. And with me would be Dr. Rajiv Sinha. So see you all next Saturday, same time. And we hope that we can bring in some more knowledge in the domain of kidney. Thank you all. Have a very good evening and a very good weekend. Thank you, sir. Thank you, Prasanna sir. Thank you, Arjay. Thank you.
Thank you very much. Thank you. Thank you. Bye-bye.